Can you see my screen, sir?
Yes, very clear. We can hear you clearly.
Okay. Okay, good afternoon, everyone. I'm Dr. Wesson Pius, A. Espiritu. Let's talk about some of the pearls when we are talking about the treatment for meniscus tears. And hopefully, you can utilize what you will learn here in your future examination. Meniscal tears are the most common indication for knee surgery. And remember that it is at a higher risk in ACL deficient knees. But we should bear in mind that yes, it can be injured in sports, but it can also be degenerative in nature. Recurrent episodes of pain and swelling, mechanical symptoms such as catching, popping, or locking are the most common presentation of this kind of injury. The hallmark of a meniscal tear are presence of an effusion, joint line tenderness, and positive McMurray test. But the most significant sign of meniscal tear is tenderness to palpation along either the medial, if we are testing the medial meniscus, or the lateral joint line, if we are testing the lateral meniscus. This is the most significant sign of meniscal tear. And as discussed in the previous lecture, special tests can aid in the diagnosis. Treatment options includes non-operative versus operative. Operative, we can do repair, we can cut it, or we can replace it by transplantation. But before diving into each options, what do we need to consider in choosing the most appropriate management in this kind of injuries? Factors to consider when deciding whether to resect or to repair a meniscal tear. Remember that the Philippine College of Surgeons loves meniscus. P stands for patient's age, C for chronicity, S for size, L for location, and M for morphology. With regards to the patient's age, there is no limit to a meniscal repair, but most surgeons would favor resection over repair if the patient is over 40 to 50 years of age. Why? Because there is a decreased intrinsic and perimeniscal cellularity in patients greater than 40 years old. And the vascularity of the menisci has also been shown to diminish and become more peripheral with age. But again, this is just one factor, and we need to combine this with the other factors to come up with a good management plan because the goal is to preserve as much as meniscus as possible. Now, with regards to chronicity, tears are considered chronic after 8 to 12 weeks, and with chronicity, the meniscus becomes shredded and tear complexity increases with time and is no longer suitable for repair. So options for repair decline and debridement or meniscectomy may be indicated in chronic cases. Now, size. Tears larger than 20 millimeter in size are normally resected, and yes, indeed, size matters. Now, location. A capillary network that originates in the synovium as seen in the picture to your right provides a direct blood supply to the meniscus, but only in certain zones, as discussed earlier. The peripheral outer third of the meniscus is known as the red zone, which has an excellent prognosis for repair, as the blood supply is directly provided in this zone, in contrast to the tears in the white zone. As we go more central, blood supply decreases. Tears in the white zone are resected because they have a low degree of vascularity and their chances of healing are very low. Tears in the white zone have classically been treated with debridement and meniscectomy rather than repair, again because of the low likelihood of successful healing in this area of a vascular tissue. Medial tears are more common. Degenerative tears in older patients usually occur in the posterior horn of the medial meniscus. And you might want to remember that if we are talking about medial, we are talking about the matanda or the elderly because they are the ones suffering from degenerative tears. Medial meniscus starts with the letter M. Matanda starts with the letter M. So if you want to say it in English, You must remember mother, granny, goose. Mother starts with the letter M. Medial starts with the letter M. Lateral tears are more common in acute ACL tears, and you can notice that ACL, the last letter for ACL is letter L, because the more commonly injured meniscus, and when we are talking about ACL, is the lateral meniscus. That starts with the letter L. Now, morphology, it can be vertical when the tear is going from superior going inferior, horizontal inside to outside, longitudinal if the tear is going from anterior going posterior, or if it is a radial or parrot beak. Combination of these four basic patterns make up the other types of tear. No? Vertical, longitudinal, the bucket handle, wherein it's a vertical tear which may displace into the notch. And remember that a horizontal tear is more common in older population and associated with meniscal cyst. Now we know the factors that we need to consider. Now let's go to each treatment options. For the non-operative management, the patient should be informed that some meniscal tears become asymptomatic after several months of protection of the joints. In middle-aged and old patients with chronic degenerative tears, partial meniscectomy has no benefit compared with non-operative treatment. Surgical management for this type of degenerative tears should be considered only in select patients with concordant symptoms who failed non-operative management. Non-operative management is a cost-effective means of obtaining equivalent functional outcomes at 1 year while avoiding the potential risk of surgery. Non-operative management includes NSAIDs, activity modification, and protected weight bearing. It includes ice, application of moist heat, compression bandages, and as I said, NSAIDs. Rehabilitation treatment provides knee mobilization, muscle strengthening, and no load restriction. Now, let's go to the operative management, starting with meniscectomy. If the patient continue to have pain, swelling, locking or catching symptoms, then operative intervention is indicated. And our main objective here is to achieve a stable peripheral rim by removing any unstable fragments that can cause the mechanical symptoms or pain. Biomechanically, as the portion of the meniscus that is removed increases, greater contact pressures are experienced by the cartilage, which leads to altered knee mechanics. Meniscectomy of at least 10%, as discussed earlier, of the total medial or lateral meniscus volume was significantly correlated with larger and more severe chondral lesion. Consider repairing and minimizing the resection of even a small lateral meniscal tears to prevent the potential deleterious effect of partial meniscectomy. Early objectives after surgery are control of pain, maximum knee range of motion, and full load walking. We said earlier that we want to preserve as much as meniscus as possible, so we repair as long as the meniscal tear is repairable. In younger and more active patients, meniscal repair remains the preferred method of treatment for unstable meniscal tears and may play an important role in optimizing knee function. It provides improved long-term outcome, better clinical outcome score, and less severe degenerative changes compared to partial meniscectomy. So what are the indications? Peripheral, if the tear is peripheral, located in the vascular red zone. If it is a vertical and longitudinal tear rather than radial, horizontal, or degenerative. And the highest success when done with concomitant ACL reconstruction and poor result with untreated ACL deficiency. For example, you have an ACL deficient knee with a meniscal tear. You repair the meniscus, but you did not do anything about the ACL deficiency. It will lead to a poor outcome. Diagnosis of a repeat meniscal tear, remember, after repair is most accurate with MRI arthrography. Meniscal repair techniques. Number 1, inside-out technique. considered the gold standard for repairable tears of the medial and lateral menisci despite the recent popularity of the implant-based all-inside devices. It will allow for fine precision, greater number of sutures, and advantage of not having a prominent intra-articular device, not including, of course, the financial aspect of this one, because you will not need an implant. The cost will be greatly decreased. Inside-out technique also eliminates the risk of implant migration within the joint that can cause damage to the cartilage surfaces that had been described with the all-inside devices. Now let's go to the all-inside technique. This uses suture devices with plastic or bioabsorbable anchors. The all-inside techniques have been developed to reduce surgical time, technical difficulty, and risk to neurovascular structures. Lastly, the outside-in technique, it is recommended for anterior and middle segment meniscal tears. It also avoids leaving prominent intraarticular material. Posterior horn actually can be also repaired using the outside-in technique, but you have a higher risk of neurovascular injury. Low-cost procedure, again, because you will not use an implant compared to the all-inside. Unfortunately, damaged meniscus tissue is not always amenable to repair, and meniscectomy is unavoidable. Concomitant procedures such as osteotomy for malalignment, articular cartilage restoration may be necessary in order to ensure an optimal result following meniscus allograft transplantation. The indications are the following. So, malalignment when present should be corrected prior to transplantation. In other words, a lateral meniscus transplantation should not be performed in a valgus-aligned lower limb. No? So you want to correct the malalignment first, the bony malalignment, before proceeding with transplantation. Ligamentous instability and more specifically ACL tears should be addressed surgically prior to or in combination with transplantation, because ligament reconstruction will protect your transplanted meniscus as much as the meniscal allograft transplantation will protect, on the other hand, the ACL reconstruction. Number 3, presence of cartilage wear in the affected compartment significantly reduces survival of the knee joint. Surgical cartilage restoration is advised in these cases because it has been shown that the presence of cartilage degeneration is a prognosticator for transplantation failure. So, after discussing all of those things, what do we know now? No? Current literature. Arthroscopic partial meniscectomy versus non-surgical or sham treatment in patients with MRI confirmed degenerative meniscus. It's a systematic review and meta-analysis. In this paper, total of 605 patients, mean age of 55 years old. The arthroscopic partial meniscectomy group showed a small improvement over the non-surgical or sham group on knee pain at 2 years follow-up. But the overall knee function and health-related quality of life did not differ between the two groups. On this one, comparison of arthroscopic partial meniscectomy to physical therapy following degenerative meniscus tears, a meta-analysis. In this paper, patients had to be greater than 40 years old, and they excluded patients with the diagnosis of obstructive meniscal tear, meniscal repair, or concurrent ACL lesion. This includes 6 randomized controlled trials with a total of 1,006 participants. 495 underwent arthroscopic partial meniscectomy and 511 were in the physical therapy group. In the treatment of degenerative meniscus tear, arthroscopic partial meniscectomy yielded better functional and pain outcome compared with physical therapy, remember, in the short term, but comparable result during the measuring the long-term outcome. A meta-analysis comparing meniscal repair with meniscectomy. Meniscal repairs have better long-term patient-reported outcomes and better activity levels than meniscectomy. Besides, the former meniscal repairs have a lower failure rate. On this other paper, especially when we are talking about the root, clinical and radiological outcomes of meniscal repair versus meniscectomy for medial meniscus root tears. Better outcomes were seen after meniscal repair compared with partial meniscectomy for medial meniscal root tears, with greater improvements in the lesion scores and lower rates of progression to knee osteoarthritis and lower ROI operation rate. Now, my last slide. We are talking about the different techniques, inside out, all inside, and outside in. On this paper, the comparison of all inside and inside out suture technique. 3 randomized control trials and 3 prospective comparative studies were included. There were no significant differences in clinical outcomes, such as meniscus healing rate and perioperative complication. Both all inside and inside out meniscal suture techniques are equally effective in these patients. But again, if we are talking about your examination and if they ask you about the gold standard is the inside out meniscal repair technique. So this is my last slide. Thank you very much for your attention.
Thank you.